Welcome to today's discussion on emphysematous cystitis, a rare and potentially serious infection of the urinary bladder characterized by the presence of gas within the bladder wall and lumen. This condition requires prompt recognition and treatment to prevent severe complications. Let's delve deeper into understanding this unique urinary tract infection. The primary culprit behind emphysematous cystitis is bacterial infection, most commonly caused by Escherichia coli, Klebsiella pneumoniae, and Enterobacter aerogenes. These bacteria are glucose fermenters, meaning they produce gas as a byproduct of metabolizing glucose in the urine. Other causative agents can include fungi like Candida albicans. However, the presence of these organisms alone isn't enough. Predisposing factors are crucial. These often involve impaired glucose metabolism, most notably diabetes mellitus. Poorly controlled blood sugar provides ample glucose for these bacteria to ferment. Other risk factors include immunocompromised states, chronic urinary retention, neurogenic bladder, indwelling urinary catheters, and, in rare cases, bladder outlet obstruction. The pathophysiology of emphysematous cystitis centers around the gas production by the infecting organisms within the bladder wall and lumen. In individuals with elevated glucose levels in their urine, the causative bacteria metabolize this glucose, producing carbon dioxide, hydrogen, and other gases. This gas accumulates within the bladder wall, leading to inflammation and potentially tissue necrosis. The gas may also dissect into the surrounding tissues, causing emphysema beyond the bladder itself. The impaired immune response, often seen in diabetics and immunocompromised individuals, hinders the body's ability to fight off the infection, allowing it to progress more rapidly and severely. Emphysematous cystitis is considered a rare condition. Due to its strong association with diabetes, the prevalence is higher in diabetic patients, especially those with poorly controlled blood sugar. While exact figures are challenging to obtain, studies suggest that it accounts for a small percentage of complicated urinary tract infections. It's observed more frequently in women than in men, possibly due to anatomical differences and a higher incidence of urinary tract infections in women. Older individuals are also at higher risk, likely due to age-related changes in immunity and increased prevalence of underlying conditions. The signs and symptoms of emphysematous cystitis can vary, but often mimic those of a typical urinary tract infection, only potentially more severe. Common symptoms include frequent and painful urination, also known as dysuria. Urgency or a strong and sudden need to urinate is also prevalent. Hematuria or blood in the urine may be present. Patients may also experience suprapubic pain, which is pain in the lower abdomen above the pubic bone. What distinguishes emphysematous cystitis is that, in severe cases, patients may experience pneumaturia, which is the passage of gas in the urine. Systemic symptoms such as fever, chills, and abdominal distension can also occur, indicating a more widespread infection. Diagnosis of emphysematous cystitis typically involves a combination of clinical evaluation and imaging studies. Urinalysis is a crucial first step, revealing signs of infection, such as spurious white blood cells in the urine and bacteriuria bacteria in the urine. Urine cultures are essential to identify the causative organism and determine its antibiotic sensitivities. However, the hallmark of emphysematous cystitis is the presence of gas within the bladder wall, which is best visualized with imaging. Abdominal X-rays can detect gas, but computed tomography and CT scans are the gold standard for diagnosis. CT scans provide detailed images of the bladder and surrounding tissues, allowing for accurate assessment of the extent and location of the gas. Ultrasound can also be used, but is less sensitive than CT scanning. While emphysematous cystitis doesn't have strict types, the severity and extent of the infection can vary. Some classifications focus on the distribution of gas. Localized cases involve gas confined to the bladder wall, while diffuse cases involve gas spreading beyond the bladder into surrounding tissues. The severity of symptoms and the presence of complications, such as sepsis, also play a role in assessing the overall severity of the infection. The treatment and management of emphysematous cystitis are multifaceted. The cornerstone of treatment is intravenous antibiotics, selected based on the urine culture results and antibiotic sensitivities. Broad-spectrum antibiotics are often initiated empirically, that is, before culture results are available to cover the most likely causative organisms. Strict blood sugar control is vital in diabetic patients. This involves insulin therapy and close monitoring of glucose levels. In some cases, bladder drainage may be necessary, especially in patients with urinary retention. This can be achieved through a Foley catheter or, in severe cases, suprapubic catheterization. In rare instances, surgical intervention may be required to remove necrotic tissue or drain large gas collections. Close monitoring for complications such as sepsis and electrolyte imbalances is essential. Prevention of emphysematous cystitis primarily focuses on managing the underlying risk factors. Tight glycemic control in diabetic patients is paramount. Promoting good hygiene practices, such as proper hand washing, can help prevent urinary tract infections. Avoiding unnecessary catheterization and ensuring proper catheter care can reduce the risk of catheter-associated infections. Prompt treatment of any urinary tract infection can prevent it from progressing to emphysematous cystitis. Maintaining a healthy immune system through proper nutrition and lifestyle choices can also contribute to prevention. The prognosis for emphysematous cystitis depends on the severity of the infection, the patient's overall health, and the promptness of treatment. With timely diagnosis and appropriate treatment, the majority of patients recover fully. However, delayed diagnosis or inadequate treatment can lead to serious complications, including sepsis, bladder necrosis, and even death. Recent research is focused on improving diagnostic accuracy and developing more effective antibiotic regimens. Some studies are exploring the potential role of adjunctive therapies, such as hyperbaric oxygen therapy, in promoting tissue healing and reducing gas accumulation, but further research is needed to confirm their effectiveness. The field continues to evolve as we strive for better patient outcomes in this challenging condition.